within the injectable drug field, this has most commonly been seen in diabetes, to try and put people onto longer acting agents. Because again, it means more convenience, less hassle, less injections, less risk of infection, so on and so forth. So we've had a move from GLP-1 antagonists that were agonists that were originally given daily or even twice daily to now weekly preparations, and in some cases we know that there are monthly or 3-monthly preparations in development. In the field of lipid lowering, we've never had this before PCSK9 inhibitors. These are the first class of drugs that have ever been dosed less than daily in the whole field. They are dosed on a fortnightly basis or a monthly basis in some cases. But if you can get out to a fortnight or a month, can you go further? And there has been development of a small interfering RNA product which also targets PCSK9, inclisiran, and that has been shown that even giving our injections there, you can maintain efficacy, certainly quarterly, and probably even out to 6 months in the Orion 3 study that was published last year. So here we are beginning to almost get to the point of maybe 2, 3, 4 times a year dosing. So that raises the idea of, if we took a drug like inclisiran, do we have to give it as an injection, or could we put it into a depot preparation and just inject it subcutaneously so it releases slowly over a year or so, and you have to have the depot changed every couple of years or so. It's a model that's already known. It's been used in contraceptives for years. But what about going even beyond that? What happens if we can take the target molecule for any of these agents, the PCSK9 itself, and knock it out for years? And the best way of actually doing that, it's been known for ages, it's called vaccination. And it's been tried before in the lipid lowering field. There have been animal models where people have, and animals tend to have a lot more CETP-driven disease than humans do, where antibodies have been made and immunizations are done to CETP, and that has been shown to reduce atherosclerosis burden in animals. CETP, probably, that can't be done in humans, and no one's really tried it. However, now we have a bit of a hint that PCSK9, being a larger protein molecule, and therefore a better target for making antibodies than a small molecule like CETP, we might be able to do this. So there's been a very interesting study published based on an animal model of an ApoE-Leiden mouse with knockout of CETP as well. That's just to accelerate the atherosclerosis in this mouse model, which has been immunized successfully to a group of peptides that are at the front end of the PCSK9 molecule and are actually roughly where the PCSK9 binds on to the LDL receptor. So they block the relevant binding component of the PCSK9 molecule. And what this study shows is not only did you reduce LDL cholesterol by 35% in mice, which is actually quite a substantial change for mice. Might not sound it in humans, but for mice it's a big change. When they looked at atherosclerosis burden in these mice, it was reduced by approximately 75%, and especially of necrotic cores within the plaques. So they are actually converting the plaques from an advanced, nasty, aggressive stage to an earlier form in development. And when you looked at cholesterol contents, those had fallen by about 50 to 60%. So all of this is implying that though the animals might still get atherosclerosis, as they would being a severe knockout, it's far less. The then question is, if you can immunize a mouse to a protein and it is immunogenic in that mouse model, will the same work in man? If we can make it work in man, then we will have a lifelong therapy to actually do primordial prevention, particularly for familial hypercholesterolemia.